Welcome. This is Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's episode is the next in our stroke series. I'm joined by Dr. Corey Zackerson from MGH, who co-leads our Equal Stroke Initiative. And our special guest today is Dr. Chris Richards, who's the medical director of the UC Health Mobile Stroke Unit in Cincinnati, Ohio. I'm particularly excited to have Chris, as I grew up in Southern Ohio myself, and I'll give him a formal welcome of Uday.
Hooday.
So welcome, Chris. I gotta say, when we were excited to get you on today because we do a lot of chatting with medical directors, quality directors, people who are doing sort of new, innovative things in stroke care. And mobile stroke units have, in some ways, people have heard about them for a while, but they're not everywhere around the whole country. And most people probably get the same picture in their head I get, which is this ambulance going around town with a CT scanner hanging out the back. My guess is it's different and more than that, though. So when you say mobile stroke unit, what are you talking about?
Yeah, that's a great question. And, fundamentally, yes, it is an ambulance and yes, it has a CT scanner, but the crews provide acute stroke care in the back of an MSU are highly trained and they do a ton. So sometimes actually the way I conceptualize a mobile stroke unit is almost an acute stroke ready hospital on wheels. So almost that first 45 minutes of what happens in the emergency department at any stroke center is essentially brought to the patient's curbside in a mobile stroke unit. So it is a critical care ambulance. It does have a CT scan that generally only does the head, although there's some variation there as well. And there's a remote consultation with a stroke specialist who then you can give thrombolytic medications. However, of course, acute ischemic stroke is not the only acute neurological emergency that we encounter. And so mobile stroke units are also stocked to treat hemorrhagic stroke, usually to reverse hemorrhagic stroke with anticoagulation on board, certainly to control blood pressure, and then also to address other acute neurological emergencies, including status epilepticus and conditions like that.
And I mean, you sort of alluded to this just now when you talked about other neurological conditions that can be treated on a mobile stroke unit. But I think one of the things that I sometimes worry about in emergency medicine is that we have this tendency to create a solution for sepsis, create a solution for acute MI. We create a solution for stroke. And I clearly care a lot about stroke. I'm here, but we don't have mobile STEMI units and mobile this and that units. And so can you just sort of make the argument or make the case for why this exists and help people understand why is this the right thing to do for stroke?
Well, I think in acute stroke, it's a disease process that is prototypical for the minutes matter approach, right? And so when we think about really truly minutes matter, we think about cardiac arrest, we think about acute stroke. And this is really an area that the mobile stroke units can address. So even in the highest functional EMS systems, when laypersons are educated to call 911, they use the right words for stroke, there's still that requisite time from transport from scene, get to the emergency department, check in, get to the CT scanner. The mobile stroke unit truly does cut that requisite time out. The very early kind of proof of concept studies of mobile stroke units actually show that whole time that can get cut out is about a half hour or so. And so again, when we're thinking about minutes matter, and it's a little bit kind of back of the envelope. But if you say every minute that goes by in stroke, 2 million neurons die, every minute really does matter. What's probably more impactful, though, in terms of a demonstration to this point is the rate of patients who are treated in the first 60 minutes of stroke, in that golden hour of stroke. In the two big studies that have looked at this, the rates go from about 1 to 3% in the conventional EMS system, still a highly functional EMS system, to close to about a third or so. And those patients really probably end up doing the best. And so that Zackerson, again, to kind of come back again in a shorter way, it really is minutes matter in patients with acute stroke.
But minutes also partially matter because of our historical and current treatment model. We have had randomized trials where we've said, okay, we're only going to enroll patients in various thrombolytic trials if they're within 3 hours of symptom onset, not with wake-up stroke, only 4.5 hours. Okay, 6 hours, right? And so the reason I bring this up is because sometimes I wonder where if we moved away from a sort of minutes from symptom definition of treatment eligibility, right, to something different, would we sort of like, how would we then think differently about getting stroke care to patients? I think minutes would still matter, but we would think we would probably do it different, right?
Yeah, it's a really interesting thought because ultimately, and we're learning more and more about this, that for every patient who's experiencing stroke, their experience is different, right? And that's not just beyond symptomatology, but that's also in terms of how quickly their stroke is progressing. We see that in slow progressors, fast progressors. We see that reflected in some of the CT perfusion studies that are out there, and really the differential outcomes that we see in patients who otherwise, look the same going into a procedure. Ultimately, that kind of translates into a very personalized approach to stroke care. And I love to see a world where that happens, where we kind of expand out indications. We see that more with large core, large vessel occlusion patients being considered for endovascular treatment. But ultimately, when we come down to any of the patients who are very who fit the inclusion for our current therapies, even within that wide window, 4.5 hours would be the guideline recommendation, 24 hours for endovascular treatment. Still within those windows, patients who get treated faster end up doing better. We also end up seeing less side effects too, some of those complications that we fear when we give thrombolytic medications. And so trying to accelerate that process by half hour even more, we think is a patient-centered approach to care.
And I know that the research is, really sort of continuing to come out and showing the benefit to patients of mobile stroke unit care. Are there places where you're seeing that, it's more effective, or patient groups where it's more effective, or, is there sort of heterogeneity in the treatment effect, or is this just like, we should have one everywhere?
Yeah, that's a great question. Sometimes the way I think about this in terms of where a mobile stroke unit could provide the most impact, sometimes it's almost like the Goldilocks phenomenon. I will say that most mobile stroke units these days are quartered in an urban, or at least a mostly urban location. I think if the only hospitals that a population is near is the highest level of stroke care, a comprehensive stroke center, then there may be bigger bang for the buck in educating our pre-hospital care colleagues and the lay public to recognize stroke and to present to a high level of stroke care. I think the flip side of this would be a very rural location where the incident rate of stroke is fairly low. Remember that the mobile stroke unit, while it does have a CT scan, it does have the connection to a stroke specialist via telestroke and can initiate treatment. The important next step is, where should that patient be transported to? So if they have a large vessel occlusion stroke, a thrombectomy capable stroke center, or a comprehensive stroke center, at least by accreditation standards, would be an appropriate transport location. Hemorrhagic stroke, that's more along the lines of a comprehensive stroke center. If a patient may be receiving IV thrombolysis, but may not need the thrombectomy capable stroke center or comprehensive stroke center, well, those patients may be best served by staying in their community at a primary stroke center. And so you can think of a geographic location where maybe there is a close by medical home primary stroke center, but a thrombectomy capable stroke center a half hour away, a comprehensive stroke center then 45 minutes away. Those are kind of the locations where you can see a mobile stroke unit making not only the treatment decisions that much faster, but then also matching the right level of care of stroke center to the needs of the patient as well. Some of that we see reflected in rendezvous protocols. And so some mobile stroke units, while they may be quartered in an urban location, rendezvous with some of their more suburban, semi-rural, even rural partners to meet up, make those diagnoses, have the assessment, and then think about treatment and transport destination from there.
I think that's the most romantic stroke care pathway I've ever heard of in my life. But it does, I love your sort of Goldilocks, Ron, because I think that's real. There's this real challenge, and this comes up in the EMS literature and what's happening there, outside of stroke all the time, which is there's a lot of good data that says for a variety of different time-sensitive illnesses and conditions, scoop and run is the best, right? But selective intubation in the field, you get a patient with cardiac arrest, defibrillate and get into the hospital. There's a variety of these sort of scenarios. And that has resulted in, I think, this misnomer out there that, oh, it's because this stuff is really hard to do. It's really hard to deliver this kind of care. It's hard enough to do it in an ED where you've got a Pyxis and 15 carts and a resuscitation bay and everything else. How could you possibly do this in an out-of-hospital setting? But this runs counter to that, right? You're saying we can do it. Does it look the same? Like, does the stroke code deliver the same way in the mobile stroke unit? Or are there sort of conscious choices that you're making so that it's a different type of stroke code?
That's a great question. Let me actually start by kind of just explaining what the base crew is. Yeah. In person, most of the time it's 4 people, 4 trained pre-hospital clinicians. Usually there's an EMT who operates the vehicle, a paramedic, a nurse or a nurse practitioner, depending, and a CT technologist who operates the CT. And then there's typically a 5th member, although sometimes that nurse practitioner, if they're neurology trained, can kind of be this intermediary. But our virtual 5th member is that physician who is the stroke team, the stroke doc. So when you're working with such a lean crew, as our paramedic and EMT colleagues who do this day in, day out in the pre-hospital setting, they all have multiple roles, multiple hats, and work really good as a lean team. We think about this in the cardiac arrest world, where we think about the PIC crew model, where everyone kind of comes in, has the designated role. It is very similar when our crews are assessing a patient on scene. Everyone has a very specific role in terms of medication delivery. We have a lot of documentation helping facilitate that NIH stroke scale with the telestroke provider. It's even reflected when we end up treating or transporting the patient. We have usually our CT tech sitting at shotgun, helping our EMT navigate the vehicle safely on the way to the hospital. So in some respects, having kind of this very dedicated mission in front of us can actually help, I think, bring out the best in what we can do in terms of providing that really hyper acute time sensitive treatment that the MSU can.
Do you need to think about safety different? Like, do we need to have certain kind of controls in place? Do we, are you thinking about, what thrombolytic agent that you have available? Like, how do you sort of ensure that there's a lot of redundancies in the hospital setting, right? There's a lot of people. You got a lot of people looking over your shoulder. You have a lot of hard stops and soft stops built into EHRs and Pyxis. And when you go, I imagine, into the image setting, you lose some of that. How do you make sure it's still safe?
Yeah, that's a great question. And part of it is we still do have our double sign-offs between the nurse and the paramedics when we give, especially the Tenecta place. We do a lot of training. We do a lot of CQI with our crews. For our mobile stroke unit, I review every one of our runs as well, especially when it comes to Tenecta place, which a lot of mobile stroke units have transitioned to. We got to think about weight estimates if there hasn't been a recent weight in the chart. Our stroke team reviews the dosing parameters, the blood pressure parameters, the inclusion, the exclusion. And then because our patients are in Epic, it's a real-time opportunity for our stroke team physicians to review some of the inclusion, exclusion. Sometimes, however, actually being there on scene can provide the best opportunity to talk to the patient's family, the bystanders who witness this as well. And so sometimes, maybe even paradoxically, you're getting better or at least firsthand information when you're there actually on the scene with the patient and the crews when you're about to go deliver the medication.
I know Corey's got a question, but I love that point because I remember how, I still do this all the time. When we have a patient come in and there's any sort of doubt or question about last normal, that's such an important element that you'll either see like one of my junior residents, a neurology resident, or if I've got a student with me, or even I will leave so that you spend this initial part of the evaluation trying to dig down that last normal time and be 100% sure about it, because you know it impacts the next 15 decisions that are about to come. And you're so right. Being at the place where the call came from probably makes a huge difference.
And you know what? I've so as my role as co-director of the UC stroke team as well, I take primary stroke call, and I've joined my crews on scene. And usually, what I do is I actually let them, the crews, kind of take care of getting the patient situated in the scanner while I'm actually still inside talking to the patient's family and asking some of those key questions that you described, rather than playing telephone tag half hour down the road and delaying, which obviously we all see.
There's a famous story about one of our attendings here who called Kmart, where apparently this person's event happened, and had them like reviewing their security camera footage to get their like the time of the event. So it's awesome to sort of cut that out. But Arjun's right. I did have a question. It was sparked by when you were talking about nursing to nursing handoff and sort of the like double handoff processes. And I was just thinking about, there are going to be lots of emergency docs out there who are listening to this who like may end up receiving a patient from a mobile stroke unit at some point coming up, or maybe they already have, but for those who haven't, like what is the experience? What are the things like to know or to keep in mind? How does that handoff process work? What do you want them to know when they're receiving your patients?
I think the first thing is just a situational awareness that one of these may exist in your community. Now, even if you are not aware of that happening and mobile stroke unit shows up, you'll be fine. There'll be a good handoff. We do instruct our crews actually to do the same stroke specific pre-arrival notification that we have our local paramedics and EMS crews do. And so there should still be that situational awareness of a pre-arrival stroke code being called. Usually for the treats, there's also a doc-to-doc communication, or if there's kind of something more complicated about the interaction, because remember this, if the patient's been transported in the mobile stroke unit, they will have the vast majority of the time already had an interaction with a stroke team physician and have had that interaction already. The other thing to be aware of, at least from a receiving emergency department perspective, is a general sense about what the capabilities may be in the mobile stroke unit that's transporting to them. So they, as we may have talked about earlier, at its core, the mobile stroke unit is a critical care ambulance. And so it will have all the medications that an ALS rig will have, but usually they will have medications to treat hypotension. We've had multiple of our patients on Levophed infusions. They may have RSI capabilities. Another important piece that's more stroke specific is which medication is used for thrombolysis. So tenecteplase is used more and more frequently. Alteplase had been used previously, but if that mobile stroke unit is still using alteplase, the logistics of continuing an hour-long infusion is probably something that should be worked out. Sometimes that means the MSU crew has to stick around in the ED waiting for the infusion to be completed, but hopefully some operational advancements can help some sort of transition from one venue to the other. The other could be which reversal agents are available to the mobile stroke unit for ICH in the setting of current anticoagulation. Because if the mobile stroke unit has a single agent and have deliver that, of course, we don't want to deliver a second agent when the patient is received at the emergency department. Maybe even more fundamentally, though, the vast majority of the time a mobile stroke unit patient will have already received a head CT. The vast majority of the time that's a non-contrast head CT exclusively, although there are some areas that do CT angiography. Most of the time, those CT scans are diagnostic. And so if we're able to save a patient a non-contrast head CT, that would be great. But of course, part of that also is that the CT scan needs to be read. At least in our system, it kind of goes through specifically marked as the mobile stroke unit head CT and is read as a priority. And so usually by the time the patient's in the emergency department, we have a read on the non-contrast head CT in addition to the wet read by the stroke team physician.
That's good. We've had others on prior equal podcasts on stroke as well. I think there's, a good sentiment to say, hey, listen, an extra CT in the setting of an acute stroke is not the radiation risk we should be worrying about. And more importantly, that, you know, even if it's a limited non-contrast CT initially, all these patients need vessel imaging, given current sort of modalities of care, availability of care, where the guidelines are at. And so one of the things we've actually found that's really interesting is, and Corey's published some work on this as well, mostly community EDs, a lot of rural EDs that participate in EQUAL, virtually everybody has CTA capability. And so I think fortunately we now live in a world where imaging access shouldn't be the impediment to care. It's more the sort of, how do we, you know, deal with all the time delays, all the logistics obstacles, those types of things that can get in the way of time of care.
Yeah, I absolutely agree with you. CT angiography is a very standard part of our workup for our regional partners, for our stroke team as well, and for our mobile stroke unit patients. We actually do have the capability to do CT angiography, but it's only from basically base of the skull. And so we actually rarely do CT angiography. What I usually tell our crews is, if we're going to do the CT angiography, let's make sure it changes something that we do, whether that's a change in level of receiving hospital, whether we're able to go directly to the endovascular suite, which we have done on a handful of occasions, in which some programs are able to do as well. And so the vast majority of the time, we end up doing exactly what you suggest, which is have them come in, get their CT angio, and then get it all in the one run, have it interpreted, have a, you know, the multiple slices that the ED scanner is able to afford, and then make our decisions from there.
Tell us one last thing, which is, you know, I have to think, and Corey mentioned this earlier, is there any models out there where people have been able to get mobile stroke units going in the absence of sort of some, you know, mega stroke research mecca, like you all that have down in Cincinnati, or I know the Cleveland Clinic has one of these units. And the reason I asked that question is because it could, I have to think this is one of those things where it's got to feel like the hurdle that you have to overcome to have this available in your community is really, really high. But are there sort of community-based healthcare systems out there that are not part of mega research institutions that are have active mobile stroke programs and have been successful?
Yeah, you bring a good point that many of the mobile stroke units that are out there have an affiliation with a downtown medical center, but that is not the only model that's out there. Actually, one example that comes to mind, our colleagues back when I was at Northwestern in Chicago, the community hospital way on the west side of town actually was able to put up one of the very first mobile stroke units and service a very semi-rural suburban community center out of a community hospital. That was a comprehensive stroke center, but that was kind of the dedication to the community in that setting. So a lot of it comes back to what we probably usually think about when it comes to kind of initiatives and that we think about, which is thinking about a champion that can really move along a project. And you know, we didn't talk too much about funding, but there are certainly startup costs. The ongoing operational expenses are not negligible, of course. And so a commitment to the sustainability to the community is usually requisite for sustainability of these programs.
Yeah, that's helpful. Chris, this was great. I learned a lot more today in a few minutes with you about mobile stroke units than I've ever probably been able to glean from the various TV commercials or talks that I've seen at a meeting, you name it. It does really sound like there's a tremendous amount of promises model. And I will sort of call out one thing you said, which I think is a big deal, which is that it's not just about treatment, which is, I think, obvious to many of us that these mobile stroke units can offer earlier treatment. But I think the nuanced thing you mentioned that is where the healthcare system's going is it's also about transport. And so this, you know, potentially is a model by which we could get patients to the right hospital, avoid a bunch of repeated transfers. There are huge sort of population health, costs of care, quality and value implications that I sort of hadn't thought about before. And so thank you for coming. Thank you for sharing with us, making us a little bit smarter, and hopefully we'll have you back in the future.
Well, we have a mantra in EMS, which is the right care at the right time to the right place, and this use really help facilitate that. I really appreciate the time and space to have a conversation with y'all. Thanks for the invitation.